Good day. Konnichiwa. It's a great pleasure for me to be here with you. I'd like to thank the Japanese Society for AIDS Research for this invitation. I'm just so sorry that I can't be there with you in person. We did try, but COVID-19 pandemic had other ideas. And so I am here with you today virtually. What I want to share with you is over the next 30 minutes is my impressions and understanding of what is it going to take to achieve control of the HIV and the COVID-19 pandemics. And I want to specifically focus on what happens when these two pandemics collide. And I hope that this will give you an idea of the challenges we're facing in these two pandemics. What I want to cover, I'll start off very briefly with just an overview of these two pandemics. I'll go on to the collisions at 3 levels. I'll start off with the collision at the level of health services. I'll go next to the collisions at a clinical care and looking at outcomes. And then finally, I'm going to look at the collisions in terms of the immunological aspects and the virological aspects and how they impact prevention. And finally, I'm going to draw on 10 key lessons that we have learned from the HIV response that's relevant for COVID-19. So, let's start with what is the situation at a global level. As we look at these two pandemics, the HIV and COVID-19 pandemics, and looking at them at a glance, the HIV pandemic, since the first cases were identified back in 1982, we currently have 38 million people living with HIV. And just in this last year, about 1.5 million new infections. Compare that with the situation we are facing with COVID-19, where in the matter of just under 2 years, we have had 250 million cases and about 5 million reported deaths. These are two major pandemics, each causing their own devastation. Both HIV and COVID-19 are more than mere viral infections. Like the HIV pandemic as it started in the 1980s, when it caused widespread famine, hunger, poverty as it waded through communities in Africa, as it led to all kinds of conspiracy theories about its origins, as it led to political protests and large numbers of people dying, and as it led to disparities, especially against those who had different sexual orientation. All of those challenges that we dealt with in HIV, they have come back to haunt us in COVID-19. In COVID-19, as the World Bank has pointed out, that 150 million more people are now extremely poor. And as the World Food Programme has highlighted, that in the course of the COVID-19 pandemic, 161 million more people are going hungry each day. And we are in the midst of what the WHO has called an infodemic, a deluge of information, particularly in the uncurated and unedited forms of social media. We see all kinds of conspiracy theories emerging. And we've seen the political instability, the protests against the COVID-19 restrictions, just in many of the same challenges that we have seen, but none more so than the way in which COVID-19 has highlighted disparities on race, on gender, and in terms of treatment and vaccine access. The very challenges we faced some 30 years ago in dealing with HIV, we are now dealing with them in COVID-19. So let's look at these collisions. Let's start off with focusing at the level of health services. What we have seen in many poor countries is how HIV services have indeed enhanced our COVID-19 response. Many of the same infrastructure that we have used for HIV has now become important in the COVID-19 response. Let me give you 3 examples. When it came to the first cases and the initial establishment of surveillance for COVID-19, it is the very same platforms that were used for HIV viral load monitoring that were now being used for PCR testing for COVID-19. Our whole genome sequencing capacity that was built to deal with drug resistance in HIV became the basis for phylogenetic analysis of SARS-CoV-2 so that we could better monitor and survey the number of new variants and look for the emergence of new variants. And finally, as we saw with HIV throughout Africa, the infrastructure that was built to test HIV vaccines is the very same infrastructure that was utilized for COVID-19 vaccine trials. So we have seen how all of the work that went into building the HIV response is now contributing to the COVID-19 response. But we've also seen how COVID-19 has negatively impacted HIV services. In an article that Kureisha and I published in Science, which is on the left-hand side, and my team here in Caprica and Durban published in Lancet HIV, in an analysis of 65 facilities, what we found was that during the stage 5 lockdown, during the severe form of lockdown where stay-at-home orders were provided, we found that even though clinics and hospitals and healthcare services remained open, people were just too scared to go there. After all, that's where the COVID patients were. And so what we began to see is the way in which HIV services were compromised in that period. We saw HIV testing decline by 47%. We saw antiretroviral treatment initiations decline by 46%. But fortunately, because it was a short-lived intervention, that we were able to recover from those losses. And fortunately, those who needed antiretroviral treatment found a way to ensure that they would get it. So we saw no marked change in antiretroviral treatment collections from the clinics and hospitals. Let's look now at clinical outcomes and clinical care. In this slide, I'm providing you with an overview of how HIV infection has impacted outcomes in COVID-19. I don't mean for you to look at the detail here. I'm providing it so that you know that there is a meta-analysis that has been done of the available studies. Let me just touch on the 2 key trends that we have seen. Most of these studies show that individuals with HIV have similar outcomes to people without HIV. But some have suggested that outcomes in people living with HIV tend to be more severe than HIV-negative individuals. Now, the smaller studies tend to show, when they look at individual outcomes, they tend to show no difference. But the larger studies show effects that are quite interesting. So let's look at some of those effects from large studies. So in this retrospective analysis of just over 17 million people who had, of whom about 27,000 had HIV, what we found was that the probability of death was about 3-fold higher in people living with HIV than in people who were HIV negative. The challenge with interpreting this is that those individuals in the UK who had HIV, they tended to be more often male, they tended to be more often black, they tended to be more often from deprived geographical areas. And indeed, the hazard ratio, the increased risk of death among black individuals was 4.3-fold higher. So this HIV difference may be confounded by all of these other factors. Let's look at another study, this time from the USA. In this US study, in a cohort that looked at just over 1.4 million individuals, of whom about 26,000 were COVID-19 deaths, and of those, about 445 were individuals with HIV. What this study showed is that people living with HIV had a slightly higher risk of hospitalizations and deaths. There were also increases in adverse outcomes. They were associated with male gender, with being black. And so those are again confounders that may be responsible, may be contributing to some of these small differences that we see. One of the interesting things was that viral load suppression was associated with less hospitalization, so suggesting that uncontrolled HIV was an important factor impacting negative outcomes. But in this study, done in Cape Town in South Africa, it provides us with a slightly more nuanced understanding of the relationship between HIV infection and COVID-19. In this study, what was found was that individuals who had HIV had a higher risk of mortality, and that risk was about twice. So what we are seeing in this particular study from the Western Cape is that individuals who had HIV were twice as likely to die. One of the issues is that there was no difference in the study between outcomes in relation to viral suppression. And what was also interesting to note is that individuals with HIV often had comorbidities as well. So there's some level of confounding. But importantly, what was clearly observed is that while HIV largely occurs in young people, COVID-19 adverse outcomes, including death, largely occur in the older groups. And so the attributable fraction of deaths due to COVID-19 in the presence of HIV is only about 8%. So it's a small contributor because of this age differential in those who are negatively impacted by HIV compared to COVID-19. In this study, in this sub-analysis of that same study, looking at individuals who were immunosuppressed, in other words, they were taking the antiretroviral therapy, they had viral loads below 1,000, their CD4 counts were reasonable. In these individuals, the risk of mortality was about 2.3-fold. So what we've seen in the previous slide. But in individuals who had uncontrolled viral loads, in other words, more than 1,000, and who had low CD4 counts, what we saw was about a fourfold, almost fourfold higher risk of death in those individuals. So what can we say when we look at all of these data together? We can say that individuals who have well-controlled HIV and who are immunosuppressed, their risk of adverse outcomes is slightly raised, and their attributable fraction of deaths is also quite small. But individuals who have uncontrolled HIV, who are not on antiretroviral treatment or who are low CD4 counts, those individuals have a significantly higher mortality from HIV when they are infected from COVID-19. So, looking at that relationship between the two gives us some impression of how these two pandemics are interacting with each other at the individual level in clinical outcomes. Let's move on to looking at some of the immunological and virological impacts of these two pandemics colliding. Let's start off with looking at immunosuppression. So, what we have seen is that when it comes to natural infection, individuals who have HIV have lower neutralizing antibodies from natural infection compared to individuals without HIV. So there's little doubt here that immune responses in natural infection are poorer in individuals who have HIV. On the right-hand side, I'm giving you some impression of not just in terms of antibodies, but also let's look at T cell responses. When we look at individuals classified by WHO category, which is based on oxygen requirements, among those who are most severely ill, in other words, WHO stages 5, 6, and 7, we get some idea that in those individuals, as long as they don't have HIV, the T cell responses seem to be pretty well and they are intact. However, if one looks at individuals who have HIV, we see a slight decline in the proportion that are responding with T cell responses. Not a big difference, 83% versus 91%. But when we look at patients who have both HIV and TB, there's a drastic reduction in the proportion with T cell responses. It now goes from 91% all the way down to 40% responses. We see their polyfunctional profile is also compromised. We see activation profiles also changed. So all of these are showing the impact of the presence of HIV in COVID-19 patients that's impacting both their B cell responses and their T cell responses. But we've seen with vaccines like the Oxford AstraZeneca vaccine that individuals who have HIV have similar immune responses to individuals who do not have HIV. And you can see here how the purple and green lines follow each other in relation to time after vaccination, fairly similar. So that's reassuring that individuals with HIV will still have good vaccine responses, even though it turns out they don't respond as well to natural infection. In this study, on the left-hand side, this is the Pfizer vaccine. So it's not just against vector vaccines, but also against mRNA vaccines. What we find, regardless of CD4 count, as long as individuals are on ART, the immune responses from the second dose of the Pfizer vaccine are incredibly good. We see high neutralizing antibodies generated in people who have HIV. What is of concern is what we see on the right-hand side. In this study of 2 doses of the Pfizer vaccine given to an individual who was severely immunosuppressed, CD4 count of only 20, a viral load that's clearly uncontrolled, 800,000 plus. In this individual, 2 doses of the Pfizer vaccine, no IgG reactivity, no SARS-CoV-2 specific NUT profiles, no ELISpots for T cell responses. So what we are seeing is individuals with HIV, uncontrolled severe immunosuppression, very poor responses to vaccines. Let's look now at one particular challenge that we have with individuals with uncontrolled viral load, individuals who are not well controlled on ART. This is a patient from South Africa. What you are looking at in the orange line is you're looking at the persistence of SARS-CoV-2. So this is PCR positivity for SARS-CoV-2. And what's interesting, if you look at the orange line, you can see that this person had persistent infection. For 7 months, this individual was COVID-19 positive on PCR. Now, this individual was quite severely immunosuppressed, CD4 count of only 6, a viral load of 34,000. And even the CT value on the PCR for SARS-CoV-2 showed quite a high viral load at 18.5. And what we saw in this individual is that in her persistent SARS-CoV-2 infection, it resolved just after 7 months when she was put onto an effective antiretroviral regimen. So when her regimen was changed to a dolutegravir containing regimen, she suppressed her HIV viral load and she cleared her SARS-CoV-2. And you see that how both the blue and the orange lines decline quite rapidly from day 190 onwards. So what happens in those 7 months? Well, we looked at this particular patient and we looked at the genetic mutations in her coronavirus over that 7-month period. And it was striking. The first thing we saw was that she had originally been infected with the D614G variant. But within the 7 months, she developed 11 new mutations, 7 of which were in the receptor binding domain. What was particularly concerning about this patient was that by day 6, she developed the E484K mutation. Now, the 484 mutation is a particularly important mutation because it confers immune escape to vaccine and natural antibodies. Because what happens at position 484 is that naturally the virus and the ACE2 receptor at position 484 are both negatively charged. When there is a mutation at position 484, the virus becomes positively charged. And so that positive charge leads to much stronger affinity between the virus and the ACE2 receptor at position 484. So position 484 is a critically important one. In this particular patient, she developed it within 6 days, showing how important that immune escape mechanism is in this virus. By day 71, she developed the mutation at position 417, again also an immune escape mutation. And finally, by day 190, she developed the 501 mutation. In essence, the 501, 417, and 484 mutations, the 3 key mutations that define the beta variant, we saw in this patient how she recreated the beta variant within the 7 months of her persistent infection. What was interesting, of course, in her is that she also had widespread HIV drug resistance. She had resistance against tenofovir, FTC, and efavirenz. And as we changed her antiretroviral regimen, she cleared even that drug-resistant strain of HIV. So what we are seeing is that effective treatment, she cleared the virus, both HIV and SARS-CoV-2. So antiretroviral treatment is critically important for the control of SARS-CoV-2. So let's look at what do we know about vaccine guidance for individuals who have HIV. Well, the first is that all the clinical trials that have been done, and several have included HIV patients, what we have seen is no safety signals. The UK guidance suggests that a 3rd dose of Pfizer vaccine should be given to all HIV-positive individuals above the age of 12 who have a low CD4 count. In other words, who are immunocompromised. And ideally that 3rd dose should be given once the patient is resuppressed on antiretroviral treatment. The CDC guidance in the US also suggests that an additional 3rd dose of the vaccine be given to all those who are above 12 who have HIV infection with advanced or untreated HIV. So clearly what we are seeing is the importance of individuals who are immunosuppressed in HIV ensuring that they are vaccinated and that they get a 3rd dose or even a 4th dose if needed to ensure that they respond by developing an appropriate response. The reason is that if they do not have vaccine protection, they run the risk when they get infected of developing persistent infection and developing and creating new variants of the virus through the multiple mutations that occur. Just for completeness, giving you some sense of the gaps that we currently see in our knowledge of HIV and COVID-19 co-infection, we don't yet fully know and understand the long-term durability of both humoral and T-cell responses to COVID-19 vaccines. In fact, the efficacy and the immunogenicity of the additional doses that are being proposed and recommended both in the UK and the US, we don't really know their full benefits yet. And clearly we need to be thinking about, as we go through getting the younger ages vaccinated against COVID-19, we're going to have to know about the vaccine safety, immunogenicity, and efficacy in those who are younger in our population. So I hope I've given you through all of that a sense of the challenges we face with severely immunocompromised individuals with HIV. So how has vaccine research for COVID-19 benefited or led to the translation and improvements in HIV vaccine development? Well, there hasn't been a direct one-to-one relationship. Making vaccines against SARS-CoV-2 is a lot simpler than HIV, for one very simple reason, that HIV has reverse transcriptase and so creates a reservoir of infection in dormant T cells. But the 5 classes of vaccines that have been shown to be effective for SARS-CoV-2, particularly mRNA platforms, are now creating a whole new area of research on HIV vaccines. And we've seen the first of those in a study being undertaken by the Scripps Institute with Ayavi and several others. mRNA vaccines are being made to do germline targeting. That in looking at new ways of recreating broadly neutralizing antibodies in humans against HIV, a completely different approach is being considered with the use of mRNA vaccines. So yes, what we've learned from SARS-CoV-2 vaccines is of some benefit as we think about moving forward with HIV vaccines. So let me move on now to the last point I want to make, and that is to share with you 10 key lessons from HIV for the COVID-19 response. Let's start off with what do those 10 lessons mean? And I'm going to go through each of these as we deal with trying to understand how can our response to one pandemic assist us in our response to the next. So let's start off with one of the key things we learned in HIV. Know your epidemic, know your response. Indeed, for HIV, UNAIDS puts together very detailed documentation about the epidemiology of the virus. We see, for example, these kinds of hotspot analyses to give us the ability to target our HIV responses. We have guidelines for how to use surveillance in order to know our epidemic. In knowing our epidemic, then we can guide our response. In COVID-19, we've tried to do the same. In this hotspot picture that you see, this is a part of Cape Town where we have plotted all of the cases that have occurred to identify where these cases are occurring so that we can focus our response. And it turned out in this particular area of Khayelitsha, in just outside of Cape Town, we found that the local supermarket was the main source of the spread of this virus. And so we used that information to guide our response in that particular area, to bring down the peak of the viral infection. So using information to respond has been critical in HIV, and we've learned from that, and we've used that approach in COVID-19. The second is the centrality of scientific evidence in how we respond. In HIV, we have very detailed reports. We try to understand the epidemiology. We understand the modes of transmission. We target our approaches based on that. In SARS-CoV-2, in COVID-19, if you take South Africa, very early on, as the first cases emerged, we drew up an 8-stage plan, very well mapped out in relation to the available science, and that was published in the New England Journal of Medicine. So what we are seeing is the value of scientific evidence in guiding that response, because we've seen the opposite. We've seen how in HIV, the previous president of South Africa was a denialist, and how that negatively impacted the HIV response in South Africa. Sadly, the US went through a similar experience in COVID-19, where the previous president, President Trump, simply ignored and denied the fact that this was a pandemic. Oh, don't worry, it's going to disappear when it gets hot in the summer. Well, that kind of political approach that doesn't acknowledge the importance of this disease, does not acknowledge the challenge that the country is facing and the world is facing, simply does not enable us to use a scientific approach to deal with the response. And we've seen that, how in HIV we've had conspiracy theories galore. In COVID-19, it's been even worse. And in one particular analysis in COVID-19 undertaken by the New York Times, in this article in the New York Times, undertaken by a group of researchers at Cornell University, they found the role of the president in spreading misinformation was critically important. So we're seeing the importance of ensuring that we use the scientific evidence available in guiding our response. So let's look at the third lesson. And the third lesson is that leaders need to be consistent role models. In HIV, we are very fortunate in President Mandela being a force for positive change, being a consistent role model, tackling the challenges of HIV and TB. Fortunately, in South Africa, similarly, we had President Ramaphosa, who took on the challenge of COVID-19, who was consistent in his messaging, ensuring he led by example. But we've also seen examples of leaders who have done the opposite. In the HIV pandemic, the king of Swaziland, now called Eswatini, created an edict that nobody will have sex for a year in order to try and stop the spread of HIV. But shortly thereafter, he had to pay a fine because he broke his own chastity vow by making one of the queens pregnant. We saw in the UK how Dominic Cummings, one of the key advisors to President Johnson, breaking the lockdown rules. So we cannot have leaders who are breaking the rules and who are not setting a good example. It does not help in the overall response. And we've seen that, for example, with hydroxychloroquine, how President Trump promoted hydroxychloroquine, even when the evidence was overwhelming that the drug does not work. And this is not something that is neutral. There is a negative effect to using a drug like hydroxychloroquine because it's a vital drug for patients with other conditions, including autoimmune conditions. And so when this drug was now being promoted for its use in COVID-19, those who really needed it were not able to lay their hands on it. So let me deal with lesson 4, that shortcuts in science can be dangerous. And we saw that again. I'm using hydroxychloroquine as the example here of how it took rigorous studies to show that the initial studies that took so many shortcuts simply produced the wrong answers. Those studies, which we now know were withdrawn from the journal, that showed a benefit of hydroxychloroquine have now been completely debunked and have been set aside. And now we know that there is now strong and compelling evidence that hydroxychloroquine simply doesn't work. But the damage is done. The damage is done because shortcuts were taken and they have dented the role of science and the importance of science in ensuring that we have reliable outcomes and data. Let me deal with lesson 5, and that is the prevention toolbox. We saw in HIV that you can't take the approach that there'll be one silver bullet that will solve the entire HIV problem. Simply does not work. Right? In HIV, we needed to use the full panoply of all of our prevention measures. Our behavioral intervention measures, our HIV testing and counseling, condoms, the promotion of treatment, the promotion of PrEP, of circumcision, all of these have been centrally important in our HIV prevention toolbox. In COVID-19, similarly, we have seen the value and the importance of using our entire COVID-19 toolbox, not just focusing on just vaccinations, but ensuring we use vaccines, which are an essential component of our prevention toolbox, together with contact tracing, isolation, quarantine, social distancing, mask wearing. All of those together will enable us to control this disease. Let's go now to the sixth lesson, the importance of testing. Testing, especially when it's done quickly, the value of rapid testing. We saw how HIV, when we first started, we were doing Western blots. It took 3 days to get a result. By then, there was so much damage that was being done. In COVID-19, similarly, we saw how the delays in treatment were compromising isolation and quarantine requirements. Now, we have the ability to do these tests rapidly. Just like how we were able to do them for HIV, we can now tell somebody whether they've got SARS-CoV-2 within a matter of 15 minutes. That transforms our prevention paradigm, the ability to test and to identify those who are infectious. The seventh lesson is that it's really a challenge to achieve behavior change. In HIV, it was a major challenge to try and get individuals to use a condom. All of our efforts to achieve behavior change. Well, we saw the same in SARS-CoV-2. To get people to wear masks, to ensure that they maintain their social distancing, they sanitize, all of those behaviors are a major challenge to ensure that you get them implemented and that you sustain them over time, because complacency sets in. The eighth is the importance of community engagement. In HIV, it's an essential part of our response. In SARS-CoV-2, similarly, we built community engagement into our overall response, providing guidelines on how to engage with communities and bring them to make them own the COVID-19 response. Let me look now at the ninth lesson that HIV has, that it is centrally important to ensure that there's equity and that it is part and parcel of our efforts to achieve universal health coverage. In COVID-19, similarly, we've seen the value and the importance of using all our efforts in HIV and COVID-19 to improve access and universal access to health care. Let me end off now with the last point I want to make. And this for me is the central, most important point, that HIV has to teach COVID-19. And I'll draw on a report from UNAIDS entitled "How AIDS Changed Everything." Let me quote, I quote, "The AIDS movement demonstrates that with a shared vision, shared responsibility, and through global solidarity and leadership of people living with HIV, affected communities, and individual action, we can change the course of history." We have done it. We took a disease that was uniformly fatal, and even in the most remote village in Africa, we have made antiretrovirals accessible. We have done that through global solidarity. The Global Fund, UNITAID, PEPFAR, all of those have made this possible. We tried to do the same with the COVID-19 vaccines through COVAX. Unfortunately, it did not succeed. But that lesson is critical. And so let me conclude by quoting from Pope Francis in an editorial that he published in the New York Times. He says it far better than I could ever do. And so I'd like to quote Pope Francis. "The pandemic has exposed the paradox that while we are more connected, we are also more divided. To come out of this crisis better, we have to recover the knowledge that as a people, we have a shared destination. The pandemic has reminded us that no one is saved alone. What ties us to one another is what we commonly call solidarity. Solidarity is more than acts of generosity, important as they are. It is the call to embrace the reality that we are bound by the bonds of reciprocity, our mutual interdependence. I am safe when you are safe. One country is safe when all countries are safe. And in that vein, I'd like to conclude by quoting Pope Francis's last words in this, when he said that it's on this solid foundation we can build a better, different human future. Thank you.